Hi, I'm Anthony Fonzo. Welcome to the video recording on opioid pharmacology in chronic non-cancer pain. I have no conflicts of interest to disclose. This lecture is designed to meet the following end-of-week learning objectives: relate the basic science of acute and persistent pain to clinical interventions, describe the major classification, role, and method of action of various pain management medications, and to discuss the major determinants and management strategies for analgesic side effects. By the end of this module, you should be able to apply opioid pharmacology principles to clinical decision-making, understand the various factors to consider when selecting an opioid, manage opioid side effects such as constipation and intolerance, and describe the mechanism of action and indications for naloxone. So why is this all relevant? Because chronic non-cancer pain affects approximately 1 out of 5 adults, and opioids can be an effective treatment for chronic non-cancer pain. Arguably most importantly, competent opioid prescribing depends on an understanding of opioid pharmacology. So what is an opioid? Opioids are chemical compounds that are either derived from the opium poppy, these are called opiates, or they're synthesized in a lab to be structurally similar to opiates. They are used most often for analgesia, and they exert their effects by activating endogenous opioid receptors. These opioid receptors are located within the central nervous system, as well as peripheral tissues like the gut wall. There are 3 main types of opioid receptors: the mu, delta, and kappa receptor, and it is the mu receptors that are most important for mediating analgesia. If we look at the left side of the slide, we see the 3 different receptors, mu, delta, and kappa, with their respective functions. So the mu receptor, which is most important in mediating analgesia, is also responsible for mediating sedation, respiratory depression, slow GI motility, as well as euphoria and tolerance. The delta receptor also mediates analgesia, as well as it modulates hormone and neurotransmitter release, while the kappa receptor, on top of mediating analgesia, is also responsible for meiosis, sedation, and euphoria. On the right side of the slide, we see the vast distribution of mu receptors in the body, including the central nervous system, as well as peripheral tissues, in this case depicted by the gut wall. Opioids vary in their potency or strength, and potency is the measure of the amount of drug necessary to produce a given effect. For example, a low dose of a strong opioid, like fentanyl, will produce the same effect as a high dose of a weaker opioid, like morphine. And potency is, at least in part, determined by an opioid's binding affinity, or how tightly an opioid binds to its receptor. So let's look at a graphical depiction of opioid potency. We have 2 opioids here, fentanyl and morphine, with the drug dose on the x-axis and the response on the y-axis. And if we follow the dashed yellow line, we can see that fentanyl is able to cause the same response as morphine, but at a much lower dose. This means that fentanyl is more potent than morphine. This is predominantly due to the fact that fentanyl has a higher binding affinity than morphine, or that fentanyl binds to its receptors much more tightly than morphine does. Now let's look at a tabular representation of opioid potency, and we're going to be looking specifically at an opioid conversion table. So in the leftmost column, we have opioids listed in order of increasing potency, with morphine highlighted in gold, because morphine is the gold standard to which all other opioids are measured against. The first 4 opioids, codeine, morphine, oxycodone, and hydromorphone, are examples of oral formulations, whereas the last 2, buprenorphine and fentanyl, are examples of transdermal formulations, meaning that these opioids are delivered via the skin by wearing a patch. The middle column looks at the opioids equivalents compared to oral morphine 30 milligrams, whereas the rightmost column looks at an opioid's potency relative to morphine. Let's start with codeine. So we see that codeine is 0.15 times the potency of morphine, meaning that you need 200 milligrams of oral codeine to get the same analgesia as 30 milligrams of oral morphine. If we look at hydromorphone, we can see that hydromorphone is 5 times more potent than morphine, meaning that you only need 6 milligrams of hydromorphone to get the same effect as 30 milligrams of oral morphine. Moving down to the patches, buprenorphine is approximately 75 times more potent than morphine, meaning that 15 micrograms per hour over a 24-hour period of buprenorphine gets the same analgesia as 30 milligrams of oral morphine. Whereas fentanyl is approximately 100 times more potent than morphine, we see that we don't have an equivalence to 30 milligrams of morphine. And if we look below the table at the nota bene, we can see why. So fentanyl 25 micrograms per hour over a 24-hour period gives the same analgesia or effect as 60 to 134 milligrams of oral morphine. Because of this wide range, it's difficult to get an equivalence for 30 milligrams of oral morphine. And one of the reasons why this range is so large is the fact that in this case fentanyl is being absorbed via the skin or transdermally, which is much more variable than an opioid that may be absorbed by mouth. So of note is that this is just one variation of an opioid conversion table. So across your studies you may come across other versions of opioid conversion tables where the potencies are slightly different. And the reason for that is that different studies have shown slightly different opioid potencies. The potencies that have been chosen for this particular table are those that are widely used in the conversion of opioids for the treatment of chronic non-cancer pain. If we look at the last line of the slide, we can see that some opioids, such as tramadol and methadone, don't have reliably established morphine dose equivalents. So to recap, all opioids exert their effects via opioid receptors. Mu receptors are most important in mediating analgesia, and different opioids have different potencies. So let's continue with the case, Mr. K. You're asked to see Mr. K, a 65-year-old male with chronic low back pain. He has persistent, severe pain despite adequate trials of non-pharmacological and non-opioid therapy. You have decided that he is a candidate for opioid therapy. What is your approach to opioid selection? So in selecting an opioid, you may wish to consider the patient's pain severity, the different opioids' mechanisms of action, as well as patient-specific factors. Looking at pain severity, we know that more severe pain may require the use of stronger opioids. And if we look at the right column, we see that strong opioids include morphine, oxycodone, hydromorphone, buprenorphine, and fentanyl, whereas weak opioids include codeine and tramadol. The second variable to consider when selecting an opioid are the various mechanisms of action. As although all opioids bind to opioid receptors, some opioids also bind to non-opioid receptors. So tramadol, for example, also has serotonergic and noradrenergic activity, which may make it an appropriate choice in patients with neuropathic pain or with comorbid depression, for example. These same properties, however, also lead to a lowered seizure threshold, and caution must be exercised if we're going to combine tramadol with another serotonergic medication due to drug-drug interactions. Dipentadol, on the other hand, has noradrenergic activity, and it may be effective in certain states of neuropathic pain, whereas methadone has both serotonergic as well as NMDA antagonist or NMDA blocking activity, which may make it appropriate in select patients with neuropathic pain. Buprenorphine, on the other hand, due to its mechanisms of action, may be less desirable for those who wish to misuse opioids for their psychoactive effects. And this is predominantly thought to be due to its partial agonist ability at the mu receptor, meaning that when bound to the mu receptors, it only partially activates them, leading to a ceiling effect. This means that buprenorphine may give good analgesia at lower doses, while limiting euphoria with escalating doses. The second way by which buprenorphine may be less desirable for those who wish to misuse opioids for their psychoactive effects is its ability to act as an antagonist or blocker of kappa receptors at high doses. So we know that kappa receptors, when activated, mediate euphoria. So by blocking or antagonizing these receptors also serves to limit the euphoric response. Let's now look at a graphical depiction of buprenorphine as a partial agonist, where we're comparing two opioids, methadone and buprenorphine, methadone in red, buprenorphine in yellow, and we have the doses on the x-axis and the opiate effect or the amount of mu receptor activation on the y-axis. So if we start with methadone, we can see that it's able to achieve 100% of mu receptor activation or opiate effect. As it is a full agonist, it fully activates mu receptors. Buprenorphine, as a partial agonist, only partially activates these receptors, and you get that ceiling effect. And you can see how, at lower doses, may lead to good analgesia, while escalating doses really limits the euphoric effect. The third variable to consider is patient factors, as opioid metabolism and excretion varies across the patient population. Codeine, for example, is a prodrug, meaning it is not until it is metabolized to morphine that it becomes active. Now, this enzyme that converts codeine to morphine is highly variable in the population in both activity and expression, with almost 10% of Caucasians not even expressing this enzyme. And there's also a subset of the population known as ultra-rapid metabolizers, which convert codeine to morphine quite rapidly, leading to increased morphine amounts. It's for this reason that the FDA has issued a warning against using codeine in breastfeeding mothers, because if a breastfeeding mother happens to be an ultra-rapid metabolizer and they take codeine, this leads to increased amounts of morphine in the blood, which translates to increased amounts of morphine in the breast milk and may lead to fatal neonatal respiratory depression. Tramadol, while it's an active compound, can be converted to a metabolite that's up to 6 times more potent at the mu receptor, and that enzyme that metabolizes tramadol to its metabolite is the same enzyme that converts codeine to morphine. Morphine is converted to a metabolite that's also active and can accumulate in states of renal insufficiency as it is renally excreted, while hydromorphone is converted to a metabolite that's predominantly inactive, which may make it safer in patients with renal impairment. Another patient factor to consider is addiction risk, as different patients have different risks of developing opioid addiction, and some opioids are more likely or more addictive than others. So, for example, oxycodone and hydromorphone have greater psychoactive effects and thus carry a higher risk of misuse as compared to other opioids such as morphine. Quiz 1. Which opioid is most appropriate in a patient with chronic kidney disease? Is it morphine, oxycodone, codeine, or hydromorphone? Let's take a moment and pause the video. The correct answer is D, hydromorphone, because the metabolites of morphine, oxycodone, and codeine are all active and can accumulate in patients with renal impairment. Those metabolites of hydromorphone are inactive, and it is thus safer in patients with chronic kidney disease. So to recap, when selecting an opioid, consider pharmacological properties best suited for the patient in front of us, taking into consideration the patient's pain severity, the different opioids' mechanisms of action, as well as patient-specific factors such as metabolism, excretion, and addiction risk. So going back to Mr. K, you selected your opioid for him, and although he's experiencing appropriate analgesia, he comes back to your office and reports constipation. What is your approach? This is an example of opioid-induced constipation, where the opioids, by acting on the opioid receptors in the gut wall, lead to decreased GI motility. Treatment strategies may include diet and exercise, where the diet is fiber as well as increased PO fluid intake. It may include stimulant laxatives, such as Senna, which stimulate or accelerate GI transit time, as well as osmotic laxatives, such as PEG, which, by staying in the gut and using osmosis, it retains water, making the stool softer, more watery, and easier to defecate. Switching opioids may be helpful, as different opioids cause constipation to a variety of different degrees, as well as peripheral opioid antagonists may be helpful. So there's a specific formulation, an oxycodone naloxone pill, where the oxycodone is used as the analgesic, and the naloxone is used as the peripheral opioid antagonist to limit constipation. The way that it works is that the naloxone, because it's very poorly bioavailable, meaning very little ends up in the systemic circulation, is predominantly restricted to the gut and thus acts on the gut receptors to reverse opioid-induced constipation. Naloxegol is another opioid-induced or a peripheral opioid antagonist that has a similar chemical structure to naloxone, except it has a large, bulky polyethylene glycol side chain, which makes it even more difficult to be systemically absorbed and even more difficult to cross the blood-brain barrier, and thus even more so restricted to the gut and to bind to those opioid receptors there and treat opioid-induced constipation. So now you've treated Mr. K for his opioid-induced constipation, and he is no longer symptomatic. However, Mr. K initially reported an improvement in his pain from 7 out of 10 to 5 out of 10 and was able to start walking his dog again several times per day. After a few months, though, he is noting his pain is no longer manageable and has returned to its original level of 7 out of 10. What is your approach? This is an example of opioid tolerance, which is decreasing analgesic response to the same dose or requiring increasing opioid doses to achieve the same analgesic response. And this is due to the upregulation of opioid receptors that occurs with long-standing opioid exposure. Strategies to address tolerance includes opioid rotation, as well as opioid tapering. Opioid rotation, so that literally just means rotating from one opioid to another or switching from one opioid to another. The reason this is effective in treating tolerance is because of the phenomenon known as incomplete cross-tolerance. So incomplete cross-tolerance means that just because one develops tolerance to one opioid, when you switch from that opioid to another opioid, one does not have complete tolerance to that second opioid. This is predominantly due to differences in opioid binding affinities, which means that different opioids bind to the receptors differently, as well as different mu receptor subtypes. So different opioids bind to different mu receptor subtypes. We must account for this incomplete cross-tolerance when rotating or switching opioids by reducing the dose, because if we don't do that, we risk there's a slightly increased risk of overdose. Now, opioid tapering. Tapering is a gradual reduction in opioid dose, and this allows receptors to downregulate towards opioid naive levels. And this may be a strategy. This is also a strategy to address opioid tolerance. Opioid tapering, however, must be done carefully to avoid opioid withdrawal symptoms. Although they're not fatal, they may be quite unpleasant for the patient, and can be described as bad flu-like symptoms. So examples include irritability, anxiety, myalgias, GI upset, sweats, and goosebumps. Quiz 2. Which of the following is a strategy to address both opioid-induced side effects and lack of analgesic response? Is it adding a peripheral opioid antagonist, switching from morphine to hydromorphone, immediate cessation of the opioid, or adding fiber? Let's take a moment to pause the video. The correct answer is B, switching from morphine to hydromorphone, because this is an example of an opioid rotation which treats both opioid-induced side effects as well as opioid tolerance or lack of analgesia. A and D are incorrect because adding a peripheral opioid antagonist or adding fiber specifically treats opioid-induced constipation and not other side effects nor the lack of analgesic response. And C is incorrect because an immediate cessation of opioid, while that may address opioid-induced side effects, this may lead to a sudden increase in pain for the patient and is thus not the best strategy. To recap, treatment of opioid-induced constipation is directly related to its pharmacological mechanism, and opioid rotation and opioid tapering can help address tolerance. Case number 2, Ms. F. So Ms. F is a 75-year-old female on chronic benzodiazepines and was recently prescribed opioids for her chronic neck pain. She was found by family with a decreased level of consciousness and brought to you in the emergency room. She is not rousable and has a depressed respiratory rate. What is your approach? This is an example of an opioid overdose. Both benzodiazepines and opioids can independently cause sedation by acting centrally, and this can be exacerbated in patients on both types of medications. Characteristics of opioid overdose include respiratory depression, bradycardia, slurred speech, meiosis, and vomiting. And treatment is with the opioid antagonist naloxone. Naloxone is particularly an opioid antagonist at the mu receptor, meaning that it antagonizes or blocks the mu receptor. So if we look at the left side of the slide, we see an example of an opioid overdose where opioids are oversaturating the receptors in the brain. If we move to the right side of the slide, we see what happens with naloxone treatment, where naloxone, due to its higher binding affinity, is able to bind to the receptors stronger than the opioids, thus displacing them off the receptors, leading to leading to reversing the effects of opioid overdose. Multiple formulations of naloxone exist, including intramuscular, subcutaneous, intravenous, and nasal spray. And naloxone kits are widely available. Now, please note that the oral formulation is not listed here because oral naloxone, due to its poor bioavailability, is predominantly restricted to the gut, meaning that it may help with opioid-induced constipation, but will not help with the systemic or the widespread effects of opioid overdose. Quiz 3. Which of the following is true about opioid pharmacology? Oxycodone is more potent than hydromorphone. Partial agonists activate the receptor to a lesser degree than full agonists. Naloxone and buprenorphine are partial agonists. Or is it that naloxegol treats opioid-induced constipation by acting as a central opioid antagonist? Let's take a moment and pause the video. The correct answer is B. Partial agonists activate the receptor to a lesser degree than full agonists. A is incorrect because oxycodone is less potent than hydromorphone. C is incorrect because although buprenorphine is a partial agonist at the mu receptor, naloxone is a mu receptor antagonist. And D is incorrect because naloxegol treats opioid-induced constipation by acting as a peripheral opioid antagonist. The key message from today's talk is that competent opioid prescribing depends on an understanding of opioid pharmacology. By now, you should be able to apply opioid pharmacology principles to clinical decision making, understand the various factors to consider when selecting an opioid, manage opioid side effects such as constipation and intolerance, and describe the mechanism of action and indications for naloxone. Thank you very much. I hope you enjoyed the talk, and a big thank you to my friend and colleague, Dr. Abhi Sood, who helped me put this talk together.